This is going to be very informal. First of all, my name is Pachter, Barb, Debbage, and Mapp. We're the PBRN group. We'll tell you what that means. First of all, small group, which is really good. Does anybody know what a PBRN is? Heard of a PBRN? Not PBJ, not BLT, PBRN. Good, that's great, because this is going to be a real primer on what we're talking about. The PBRN is called a practice-based research network. And I think for this conference, it's important because number one, I think it's a community-engaged approach to making research more practical. And it's also a way of making research kind of fit the primary care context. And by primary care, that means patients, right? Most patients get their care. Before they go to specialists, they go to primary care, right? So we're really interested in primary care. I have to say that most research doesn't fit the primary care context. It takes a long time for the research to trickle down. So that's what we're going to talk about today, as well as talk about what we're doing here in Delaware. So we just developed Delaware's first practice-based research network. First of all, no disclosures. What we're going to talk about is, first of all, what is a practice-based research network, or what we're calling is practice and community-based research network. Why it's so important, why we're doing it. And then we're going to talk a little bit about the local context, how we've developed it here in Delaware, and specifically how we've developed it to really adhere to community-based research methods. You know, our motto is PBRN equals CBPR. Okay? And hopefully we'll convince community-based research. And hopefully we'll convince you. So before I get started on telling you what a PBRN is, I'm going to give you a fact that probably you guys know, and I mentioned it just a minute ago, how research, we all hear about research on the news and everything. But then we go to a doctor's office, and how often does the research that we heard on CNN or the New York Times or NPR actually translate to what you and your doctor talks about? You know, eventually it does, but it takes a long time for that to happen. I'll give you one example. This is an article which talks about the research regarding using antithrombolytic drugs, like aspirin, stuff that stops thrombi in your bloodstreams for heart attacks. Now, these days, to take a baby aspirin if you want to prevent heart attacks. It's the way to prevent it, okay? It's standard level of care. But believe it or not, the research that was used to show the effectiveness of things like aspirin for heart attacks was done a long time ago, and it took 13 years after that paper was published for the American Heart Association to recommend aspirin and thrombolytic therapy for heart attacks. 13 years. I mean, that's almost like a lifetime, right? How many people could have been saved in those 13 years? We knew the data, we knew the science 13 years before it was decided to be standard level of care. That's just one example. I think in general, most researchers think that it takes anywhere from 12 to 18 years for a peer-reviewed published research article to trickle down into best practices in primary care. That's called the research to practice time gap. And I don't know about you, but I think we can do a lot better than 13 years, a dozen years. I mean, these things, once it hits a peer-reviewed publication, it's considered appropriate science, we should be thinking about how can that affect patients and patients' lives right away. Okay? What is the reason why it takes so long? There are a lot of different reasons. This isn't a simple issue, so it's not just one answer to the reason for the research to practice time. First of all, most of the research that we do is not done in Sussex County, in Kent County, even in Newcastle. It's done at Boston Children's Hospital, MGH, Johns Hopkins, right? They're done in academic medical centers. And we all know that academic medical centers are not real world settings. A very, very, very small percentage of US patients get their care done at academic medical centers. Okay, and most of those academic medical centers are specialty driven. Okay, so most of the research is done not in primary care clinics, but in specialty clinics. So the population that they do the research on is also biased, separate from what we see in our primary care practices office. So therefore, the research might not actually fit the primary care context and fit the patients that go to primary care. Okay, and even if it is done in primary care centers, it's usually done in academic primary care centers. So again, we talked about how that's very different from Sussex and Kent, etc. Second, there's really poor communication between researchers and clinicians. Aside from A.D. Lee Fahn back there, who is both a clinician and a researcher, there are very, very few clinicians who actually do research. Think of them as almost two different cultures. And that's called cultural communication. There's a cultural communication gap. You know, we don't read the same journals. First of all, clinicians don't have time to read journals. They're too busy seeing patients, but the journals that they read are very clinically oriented journals. They're not the cutting edge science, okay? So that also contributes to the lag of time. It's almost like two different cultures with two different languages. And because of that, I think most research is very narrowly focused. It's very complex. It's hard to translate into clinical care. And it may not meet the perceived needs of the clinical practitioner, especially the family practitioner or the general pediatrician who sees patients, okay? And I'll give you an example. This is like a stupid example, but everybody's interested in diabetes, right? It's the most common chronic illness. We've heard about it earlier today. You know, the majority of adults either have pre-diabetes or diabetes. So how might a biomedical researcher look at diabetes? Well, they're going to think about things like novel therapeutics, epigenetics, pharmacogenomics, really important stuff, right? It is important. Now, how about the clinician, the primary care doc? What are they thinking when they talk about diabetes? They're talking about, okay, is my patient's hemoglobin A1C in order? How's their creatinine, their renal function? How are things like that? Similar stuff, but different questions. Then we get to the patient. The patient wants to know, am I going to lose my eyesight? Am I going to get skin ulcers? And am I going to need a kidney transplant? So they're all talking about the same thing, but the questions that people have in these different cultures are very, very different. It's like we're in the same building, we're looking at different windows, okay? So that could be one of the reasons why the research that's being done isn't specific to what clinicians see in practice and isn't even specific to what patients are really caring about. And that's why it takes so long for the research to trickle down. So one of the solutions to this research to practice gap is something called a primary care, a PBRN, practice-based research network. So what a PBRN is, it's basically a network of primary care doctors in the communities who are devoted specifically to clinical care. These are not researchers. These are guys and girls go to medical school and do their fellowships and residencies and go to see patients. And they're really interested in that. But they are interested in collaborating with their colleagues, but also with researchers to specifically investigate questions that are important to their day-to-day practice, that need data, that need research, that need evidence. Okay? It's united by a commitment to expand the science behind what they do every day in their practice to improve, number one, quality of care for their patients, patient outcomes, and professional satisfaction. You know, for those of us who went to medical school, when we're in medical school and when we're in residencies, we loved research, okay? Then we go to the reality of practice, and as much as we love it, it kind of becomes an appendage. And we, you know, between seeing patients day in and day out and working on your weekends to do your electronic medical records, there's very little time to kind of exercise that research scientific muscle that you still might do. Okay. Practice-based networks link frontline clinicians, your primary care docs, with researchers who are experienced in clinical health services and population health research. This is the important thing. It draws on the experiences and insights of practicing clinicians to identify and to frame research questions whose answers can improve practice. Now, as a researcher, we think about what is the research question. It's usually a hypothesis that could be either proven or disproven. That's very different from a clinical question that a clinician has, okay? So there are these clinical questions, there are these research questions. Again, that's part of the gap. They're very, very different, okay? But having a network where clinicians are involved in research, not only being consumers of research, it's an approach to translating those research findings into clinical-based, evidence-based care. And hopefully it would decrease the research to practice time lag. There's a famous like meme in PBRN world that says if you want evidence-based practice, we need to have practice-based evidence, not, ivory tower-based evidence. Okay, so that's the reason why practice-based research networks are so important, to make sure that the research that's coming out is going to affect you as patients and as clinicians. Okay, so PBRNs have been around since kind of like the 1980s. They've gone up and down based on federal funding, to tell you the truth, because it takes a lot to create a PBRN, practice-based research network. And we'll go into us as a case study. But there's something called ASPEN, which is the Ambulatory Sentinel Practice Network, which is out in the West. For those of you who are pediatricians, there's something called PROS, which is called Pediatric Research in Office Settings. So there's been a lot of efforts to do PBRNs. And they've been really, really successful. And they've actually, the research that comes out of PBRNs have been shown to decrease the research to practice gap. And I'll give you just one example. Yep, okay. So this is a study that came out 2 or 3 decades ago from this ASPEN network, the Ambulatory Sentinel Practice Network. And just to give you some background, 20, 30 years ago, when a patient came in to their primary care doctor with a miscarriage, called spontaneous abortion, but it's really a miscarriage. The standard level of care at that time, according to the American College of Obstetrics and Gynecology, is for every woman who had a miscarriage to get something called a D&C, a dilatation and curettage, which means that you had to scrape the uterine lining to get out anything in there from the spontaneous abortion. Now, we all know that this procedure is expensive, it's painful, there's morbidity to it, but that was the standard level of care, according to the experts, ACOG. Now, if you spoke with primary care docs, they say, we know that that's the standard level of care, but we don't actually do it that much because, if you're in a doctor's office and if you see patients, we found that not too many patients actually need to have a D&C. And if you do a D&C, you're not going to get a better outcome than if you just, if you can identify those patients who may need it, which is the minority. So ASPEN said, well, let's do a study of this. So they went to their primary care practices that are in the network, 30, 40, 50 practices, and they actually followed patients who went through miscarriages. And through natural selection of the doctors, they had some that had the D&Cs and some that were just treated conservatively, just watchful waiting. And what this research finding showed is that there was no difference in outcome, whether you got this invasive procedure or whether you watchfully waited. Okay? So we were able to stop a very invasive and painful procedure that was recommended by the experts. Okay, now we talked about the research to practice gap of being 13 to 18 years. After this study, in 3 years, the American College of Obstetrics and Gynecology changed their guidelines. Okay, for 3 years. So that shows you the power of primary care data and primary care research. And I can tell you a similar study with headaches and how we used to do CAT scans for headaches. And then we went through a PBRN study, showed that you don't need to do CAT scans for headaches. You can tell the people who have brain tumors, and if you do CAT scans on them, 99% of people with headaches do not need a CAT scan. And fevers in infants, Dr. Fon probably remembers that when I was doing my residency, when a kid under 2 months of age came in with a fever, we did a spinal tap. We tapped their bladder for urine. We did blood cultures. We put them in the hospital for 3 days with IV antibiotics. Most pediatricians do that. Okay, so they did a study through PROS and found out that good clinicians can tell the real sick kids from the not sick kids. And therefore, 80 to 85% of kids with a fever did not need all that type of stuff. Again, that would not have happened at Boston Children's Hospital, but it happened in doctors' offices. So those are some examples of how practice-based research can really change quality of care quickly. Okay. So hopefully I've given you like kind of justification of why it's really important to gather data in primary care practices. Now the NIH, interestingly, has recently agreed with this, saying that's really, really important. And they've actually developed, well, before this administration, they developed some programs to really change NIH funding so that a lot of it would go through primary care practices. We're not sure whether that's going to stay or not. But as part of it, ACCEL, which is an NIH program, when we were renewed for our last renewal, it became a requirement that CTRs like ACCEL worked with practice-based research networks. It's part of us getting our funding. So that was the good news. Bad news that there wasn't a PBRN in Delaware. So we had to actually develop a PBRN and then work with it. So that's why the three of us are here. And what I'd like to do now is tell you the local setting and how we developed a practice-based research network, how we're considering chronic illnesses as being like the most important part of the research that we're going to do, but also because this is the community research exchange, to tell you how we went about it to make sure that the PBRN was really community engaged. So this is our logo. We're in year 3 of our funding, but the first 2 years we're really developing the PBRN. I'll tell you exactly why, because it took a lot of work to start something like this from scratch, and we're just about to start doing research. So what we did is we decided that we were going to try to recruit primary care practice from all around the state. Obviously, Christiana Care has a strong presence here in Newcastle County, a little bit in Kent, but we wanted to make sure that our network of primary care practices were represented geographically and demographically of the whole state. How do we do this? Is that we decided that we would first at least start from the major healthcare systems. We know that there are some primary care practices who are like independent, and we definitely want them. We figured the most efficient way would be to go to these health systems who had primary care practices and work through them. So, the usual suspects: Bay Health, DB, we were trying to get the southern part of the state, Christiana Care. The Delaware Health Equity Coalition is a single primary care practice in Wilmington. La Red, which is a federally qualified health center in the southern part of the state. The Moors, obviously. Tidal Health, which also is in both Maryland and the southern part of the state. Excuse me, University of Delaware has a nurse-led primary care clinic. The VA, people don't think about the Veterans Association as a real important source of primary care for many Delawareans. So we got the VA involved, as well as earlier today, we had a representative from West Side at one of the panels. We also have the West Side. So we tried to get as many geographically and demographically diverse health systems to see whether they would allow their primary care practices to potentially be involved in the network. And how we went about it, this is a kind of top-down approach. The rest of it's will be bottom-up. But we basically went to the C-suite people, the systems leaders, the Dr. Nevins and her people, to kind of sell them on this idea of practice-based research network. Again, our selling point was this research to practice gap and how it would provide more efficient, high-level quality care early on. From the system, once we got their buy-in, then we went down to the ambulatory leadership, the directors of ambulatory medicine, the directors of primary care medicine, made the same pitch, but we were able to say, hey, Dr. Nevin et al. Said that they would support this. Now we're going down to you. So we got a good year. And then once we got the okay of the ambulatory and primary care leaders, then we went down to the actual practices. And we actually drove to the practices. Barb and I, we logged 1,400 miles going to all the practices within these networks, face to face, during lunchtime, in between patients, talking about this network. And we were pretty successful, and we're still recruiting. But as of now, we have about 33 practices in the state. And what I'm really happy about is the distribution. Okay, it's not just Newcastle County. We have almost as many in Sussex and in Kent. So hopefully, it's, there are some teaching practices. There are some real, single doc practices. But we want to make sure that we want to represent patients in Delaware. And I think we're off to a good start. And every week we're getting more practices. Okay, this is where the community engaged research comes in. So when ACCEL talks about community, our definition of community for the ACCEL research program is any potential end user of our research. It could be patients, it could be communities, it could be special interest groups, the American Diabetic Association, the American Heart Association. But who else consumes research? Well, the clinicians, right? So we identify primary care clinicians as a community. Okay, and one of the tenets of community engaged research is getting the communities that are involved in your work involved early on in the study, and for them to have like skin in the game, have them have some control. So we decided, we were very intent on this, that the research ideas would be generated from clinicians, not the other way around. In other words, we're not going to say researchers, okay, we're going to study, this new drug in your practice. What we want to do is, okay, practitioners that you see every day that are the pebbles in your shoe that keep you up at night, and what type of data might we be able to gather in your practice and other practices around the state to help you solve that issue. Okay, so that's the bottom-up approach that I'm talking about. Projects will be collaborative. So not only will they give us ideas for research, but they're going to be part of the research team. Now we know that they're really, really busy, so we're not going to make a time sink for them. But we want to make sure that throughout the whole identification of the project, that their voice is heard primarily as like the primary driver of the research. So the collaborative clinicians will be co-investigators. Practice will not just be laboratories for the research. Okay, they're going to be active participants. So this is kind of like our model. We have practice A, B, C, D, E, all 33 practices. We have researchers from UD, from DSU, from the Moores, from Christianacare. And we act kind of like as a culture broker between them, like the middleman, the marriage broker, where the practice are going to tell us what they're interested in. We're going to find the researchers. We're going to make the researchers kind of like community engaged researchers, saying you have to work with the practices on this. And that's how we're going to develop ideas. Now, we're also getting ideas from the researchers, but we're going to vet it through the practices to make sure that it fits the context of busy primary care clinics. So how did we do this? So again, we developed the network. We want to start doing research, and ACCEL is going to support the research. So the first thing we did is that we did a research survey, 2 parts. We sent out a questionnaire to all of the primary care practices in the network. Again, asking what I just said to you. What are the things that keep you up at night? If you had a magic wand to get some data, which is going to help your patients right away, what would be the most impactful questions that you have? And we did what's called the Delphi approach, meaning that we asked them to open-ended, then we compiled them into like a list, and we said, okay, pick your top 10, and we sent it back to them, and then we got the top 3 and said, okay, these are the top 3, or top 5, can you rank them? So it was an iterative approach, but it was their ideas, because a researcher might not have thought about something, but then when they saw, oh yeah, GLP-1 and obesity, that might be interesting, that's when they start to do it. So we did that. At the same time, we also had a list of all the ACCEL-funded researchers over the last 13 years and sent out emails to them saying, this is what we're doing in primary care. Might your research have a component of primary care in it? And if so, let us know what you're doing research in and what are your areas of interest. So we got the areas of interest of the researchers as well as the clinicians, okay? And believe it or not, that process, okay, this is what we asked. What are the most pressing issues in your clinical practice? And the researchers, do you have a general idea for research that might be done in primary care settings? From the process, we had 65 respondents. We identified, believe it or not, over 100 questions that both clinicians and researchers were interested in, which I think is a pretty good yield. So what we did is that we bumped them into categories, because obviously we're going to start. Oh, the other thing is that we're just starting. So we're going to hit some low-hanging fruit research right away. We're not going to be doing randomized clinical trials right away. We're not going to be using electronic health records. We want to do some really simple kind of health services, qualitative QI type research. So talking about chronic illnesses, these are the categories of research that the primary care practices were interested in. Not surprising, right? Mental health, diabetes, cardiovascular disease, obesity, maternal child health, prevention, sleep health and media, geriatric medicines, substance use disorder, social influences on health, AI, and also kind of like primary care systems, access and workflow, things like that. Those are the things that keep doctors up late at night doing their EHRs on weekends. So we then sent it out and said, okay, of these, which are the ones that you're most interested in? And the three that came to the top were mental health, obesity, and kind of workflow, primary care workflow. So we're really happy with this. We thought it was a very democratic way of identifying research topics. You know, the other part of it is that if the clinicians identify these things, they'd be more likely to participate in the research as opposed to being told what they should be doing research in. Now, ACCEL is going to fund pilot research each year through the practice-based research network. We're going to start slow. We're only going to be doing one project a year to begin with, just so we can grease the wheels, see what's see the things we don't know, basically. So we decided, well, we didn't decide. We had our annual meeting of the PBRN in June, where we had these clinicians come together. We had a keynote speaker from Aspen. It was really like a kind of a network building process, but the afternoons we broke out into sessions where we discussed two of these issues to come to some consensus. We also brought researchers into that meeting because once we knew what these ideas were, we were able to identify some researchers who did work in these areas so they could hear from the clinicians what they wanted to do. So we did breakout sessions for GLP-1 treatment for obesity, which everybody was interested in, and also primary care access, mostly things having to do with like insurance verification and stuff like that. Be more efficient in your workflow. They were both really, really robust discussions. And after the clinicians, we decided that we're going to do a project on GLP-1s and obesity primary care. And I can tell you that the discussion was about things such as, okay, if you prescribe GLP-1s, how does that affect your approach to nutrition and physical activity? Does that make it easier? Does it make it worse? Do patients don't care about it because now they're losing weight? Or do they see that as like a really important adjunct to it? These are the things that clinicians really wanted to know about. There are other things about prescribing, like how do you, what dose you start with and how do you ramp up? So there are a lot of good questions, but we've, since the annual meeting, had a work group come together. And the ideas that generate trickled up where we are going to talk about GLP use and lifestyle and comorbidities. And we have identified a team of 3 researchers from the university, kind of like really versed in community engaged research, so this fit them perfectly. And we identified a clinical lead, one of the clinical practitioners who wanted to be the representative for all the clinicians. So we want to have the voice of the clinicians, but we also want to make sure that this is not like a, we want to make it as efficient as possible. So we're going to have the voice of the clinicians through these meetings that we have, but also through a representative of the clinicians who can then bring it back to the clinicians and come back to us as we develop our program. I want to be respectful of everybody's time. So I'm going to give, this is the idea of how we develop the network and the justification. This is the easy part. The hard part, as many of you probably know as researchers and administrators, are things like, okay, IRB with like 33 practices, data use agreements, participant agreements. Well, luckily, I don't have to deal with that stuff. I'm going to have Barb come up and talk a little bit about some of the logistics, the really hard stuff that's taken a lot of time.
Good afternoon, everyone. Thank you for hanging on to the last 30 minutes of the afternoon. I'm sure you might be getting a little sleepy, you might need a little caffeine. I appreciate you hanging out here with us today. So as Lee mentioned, I'm the program manager for the Practice-Based Research Network, and my key role now is really focusing on building adequate infrastructure so we have success in that first project. And I have been in this role just over a year now, and I have a few lessons learned that I think are noteworthy along the way. First, this isn't done in a silo. This isn't done just with CTR. This, Lee, Alex, and myself. This is really the time that you need to bring the experts to the table and learn from them to develop an adequate infrastructure, again, to tee up success for us. And so I would say finding your expertise, I'm very fortunate. I've been at Christiana Care for several years now. I'm not going to say how many. And I've had relationships with the IRB, the Office of Sponsored Programs, and our legal department. So I felt like I was a little bit ahead of the curve with knowing the expertise and being able to, start that conversation with them. I'm in this new role and we can start meeting on the regular. So bring the experts to the table. I've worked in research for many years. I consider myself an expert in operations. However, I've never built a research network. So it was appropriate to dial in friends and ask how we should move forward with this work. My second note is that I think early engagement with these experts was key. I started this process very early, started meeting with the IRB director, maybe the first month after I started in the role. And we actually have quarterly meetings with the IRB to talk about our plan moving forward. One challenge that I saw along the way as I met with these key departments is that we were presenting a concept. I did not have any tangible study. I just had a concept of how we were going to work together. So I had to tailor these discussions to my audience. I could see that kind of look of, I kind of understand what you're saying you're going to do, but I don't really understand. So I changed my approach and added a visual to it. And that's when I saw the moment of, oh, I kind of get what you're saying now. From a regulatory standpoint, can anyone tell me what Smart IRB is? Smart IRB is a platform that allows one organization to rely on another IRB. As we mentioned, this is 10 organizations, 33 practices. So we're going to leverage the Smart IRB platform, and every organization is going to need to join the Smart IRB. We've made a great plan for city training. Most people are familiar with city training. However, there's a little bit of variation from organization to organization about what those components are, those requirements. We work with our IRB, and a huge shout out, I don't think Derek's here, but a huge shout out to Derek Bowden and Christiana Care IRB, that if you are a NMORS investigator, we're going to accept NMORS city training. We're not going to have you recreate the wheel, put more time into that very precious time that you have than to do the Christiana Care modules. We've also, my one question to Derek was, how do you think we should do conflict of interest? I know how it works in one organization, but how do you spread that across 10 organizations and 10 organizations with different resources and infrastructure themselves? So we have a plan in place that we will accept your conflict of interest if you're coming from Title Health and participating with us. But we are going to have you sign a waiver saying that your organization has it and you have signed off on it. But we're not going to take the responsibility of actually reviewing your conflict of interest. And the last piece of the regulatory is a recent organizational assessment that I've sent out. So every organization, who's your grant office, who's your legal department, who signs on behalf of your organization as that authority, understanding who those key players are in each organization. So as we move forward, I know the right people to contact. As Lee mentioned, it started with talking to the CEOs, CMOs of those organizations, but they're not the people I'm going to continue to work with to find out those answers. I need to make sure that I'm in the right spaces. As Lee mentioned, there are other CTRs that have PBRNs within the country, and we meet with them on I would say a regular basis as a group to share ideas and share lessons learned. And we put the question out there: does your PBRN have an agreement just to be in the network, or do you do agreements just based on funding opportunities for individual projects? And the majority, they do agreements for individual projects. We've taken a little bit of a different approach, and we have what we're developing as a participation agreement. And again, this is working with our network, our legal department here at Christiana Care, and our Office of Sponsored Programs, and the IRB, of course, to pull together an agreement that sets the stage that really creates that transparency, because this is a new network. First time Delaware is working this way together, and we want to be really we want to be very honest about what we're expecting of these organizations, build that trust, and really set the foot that this is a professional organization. That's all I have. I think I'm going to hand it back over to Lee.
Yeah. So we're just about finished, but just to summarize, and also one other thing. What's that? So you've probably seen two different things, PBRN and PCBRN. So PBRN is kind of like the model everybody uses. Because we're coming from a community engagement perspective, we call ours a PCBRN, Practice and Community-Based Research Network. And I know I mentioned how we see clinicians, primary care docs as community, but we're also interested in patients and actual real communities as well. So PBRN 2.0, once we've gone through this one time, we're going to incorporate communities as well as practices. And how we're planning on doing that, there are many different ways. Most people do have like the advisory council, central council. We're not going to do that. We figured that the people who know best who the communities who they serve are the practices themselves. So we're going to ask each practice in the network to identify a community that they think is central to their practice and bring along a representative from that community into the PBRN. So it might be a migrant worker community. It might be, oh, we see a lot of stroke, a stroke representative. It might be a demographic, adolescent. You know, we're not sure. We're going to let the practices, as the experts, identify who their communities are, and therefore make it a true practicing community-based research network. So just to summarize, before I turn it over to Brian, PBRN is a tool to decrease the research to practice time gap and hopefully make the research more impactful. Clinicians and their patients are the communities impacted by the research, and we made a very, very honest attempt to involve them as equal partners from the beginning, not just as consumers of our research. And again, PBRN equals community-based participatory research in this way. There are a lot of moving parts. You know, I had the easy part. I think Barb had the hard part, working with legal, etc. But it's working. And everybody's been really, really open and honest. Now, I don't know how many of you are community members, community-based organizations, practitioners. We welcome all ideas for what you think we should be doing research in. We have the 106 ideas. We're keeping a list, and we're adding to the list all the time. So if you have ideas, we'd be happy to hear about it. If you're interested in being a member of the PBRN, we'd be happy to hear about it as well. I'm going to stop now. I'll let you have to answer questions later, but I promise you.
You have time now if you want to get some questions. Oh, yeah, this is important.
Okay. Does anybody have questions or comments about it? Yes.
I kind of have a question. I work for Delaware Breast Cancer Coalition, so we're always working with people to get screened. Many of them that we work with in our population don't have primary care, so we're connecting them with primary care across all of those partners that you listed, really. So it's just interesting. It would seem like it might not be a bad idea to have someone who's, you know, in our agency talking to primary care, because, you know, they're busy. Do you know what I mean? They don't know what the struggles are. And even to like get something as simple as a mammogram. I mean, I recently went through that process myself, and I didn't quit because of what I do, but a lot of people would quit if they had to go through what they need to go through. Like they need help with their primary care to get it done, to get it scheduled if they don't know about us. So just, it's very interesting. I think it's really dynamic. And
yeah, and you know, the central core of this is primary care practices, but we also understand that many people don't have a primary care practitioner, and we're trying to identify ways of getting their input as well. We have a great relationship with the, for example, the Delaware library system. So we might be able to have some questionnaires at the libraries for people who go use the library and may not have primary care docs. But that's a great idea, and obviously, you know, screening for cancer, for breast cancer, is something that actually came up on the practitioners' responses.
You know, like Heather Bittner-Fagan's work with the screening for lung cancer. Similar concept.
yes.
I want to back up to that. So I'm with the DHSS, with the Division of Public Health and the Bureau of Chronic Disease. And I think the state would be a good partner in this work. Oftentimes, because we don't go after research grants, we usually apply for grants that from the federal government that are pretty prescriptive in what they want us to do. But oftentimes we need clinicians and other community partners to tell us how to do it. So I'm just wondering if there's an opportunity for state partnership.
Definitely. And as part of our kind of ongoing sustainability efforts, we certainly, you know, the state health department and the state itself is a big partner. We just haven't found out how to do it. So I'd love to speak with you. And if you can identify yourself or someone else in the state who we could talk to, that's kind of like in our parking lot of things that we have to do next. So,
and someone mentioned earlier, we're in such silos because we're so big, and everyone has a different goal or focus, but ultimately we're all trying to just improve health outcomes.
And by the way, this also improves equity as well, because the representatives that are being done, that are participating in the research is more reflective of our population.
Heard a little bit about it, so I'm so glad to hear the rest of it. My background is that I worked in cardiovascular research for many years, and tried many times to accomplish research in the community, like Stella Bauer. Let's put that out there to some of the private, and it's very challenging, particularly if you're outside Christiana's network and you don't have the IRB and the legal. So very impressive that the state is pulling this together with all those organizations. I work at Wilmington University now. I oversight the Health Sciences Division, and I'd love to talk to you about how you think you're going to train some of the private practices and the personnel within those private practices, and if there's an opportunity for us to help you with that.
That's really important. We had a plan to have a kind of like a series of online tutorials on practice-based research. And the feedback that we're kind of getting from the practices is that they'd love that. They don't have the time to typically, spend looking through it. So while we're still preparing that, we're thinking of it as going to be more of like a project-based approach, like this, for example, GLP-1. So then we can kind of, it catches their imagination, but we love to have partnerships. I think of the PBRN kind of like as a tool for researchers. I mean, as for anybody that's done research knows, it's so hard between the IRB and identifying on the ground support at the practice. Well, we have FTEs that will do that for research, that will work with researchers' teams, but we're almost offering a service to researchers to make it easy for them to do multi-site research.
Awesome.
Angie, to your point, I'd love to just add to that because, that was, I think, some of our concern in the beginning of this. What does it look like at the sites? Because every, facility has different skill levels, abilities, et cetera. And we talked about that a lot. And so bringing, someone into to partner that has a clear understanding of what it is to do research in a healthcare setting and the barriers and the requirements, the regulatory piece was a big piece. So Barb has, been focusing. So when you go back to all that kind of operational structure, organizational structure for the last year, really getting a foundation in place so we can identify the unique needs in each area, because some practices will be flush. They may have some type of research coordinator that comes in and out they can tap into.
Yeah.
Others, it could be a physician and maybe an MA that, they're seeing, patient every 5 minutes or so. So making sure we meet them where, they need us, I think.
But that's where getting your buy-in from the top down is really important because, if you have difficulty getting the manpower to support the work, you can turn to those that first endorsed it in theory, and say, you bought into this, we want to continue, this is how we want to do it. But that, that's, see, it's actually.
And the great thing about our network, being that we do have infrastructure support, is that it's not a one-size-fits-all approach. So, for example, we were at this GLP-1 meeting, and we're going to be doing a questionnaire. So the question is, okay, is it going to be an EHR questionnaire? Is it going to be a red cap questionnaire? Is it going to be a paper and pencil? And our answer is yes. Whatever your practice feels comfortable in, we could accommodate. So it doesn't have to be red cap for everybody or paper and pencil for everybody. We have the support and infrastructure to meet them where they are and to make it as efficient and easy as possible for them to say yes to us.
So you have one protocol that's going through the pipeline. Now you have a second one, I think you've envisioned, or someone in the back of your head mentioned. Where do you sit with your protocols? And
so the great thing is that kind of like if you build it, they will come.
Yeah.
We're starting with the GLP-1, but we've gotten emails and messages from people saying, hey, I've heard about this network. We're about to start researching this. Can we speak with you? So we want to start out with just one because we don't know what we don't know so far. We want to go through it one time to get all the wrinkles out. But once we've been successful in a relatively low-hanging fruit research project, we'll accept all comers as long as the practitioners agree that that's what they want to do the research in. So we do have a few other ideas, the ones that are in the parking lot now, the mental health, behavioral mental health, and the workflow is like the next one. We've gotten some ideas from the Moores about use of AI for patient education that we're interested in. We'll accept anything.
Can practices choose which one they want to be in so they don't
Thank
be
you.
in
That's
everyone?
the most important thing I failed to mention. Being a part of the network does not require a practice to be involved in the research in the network. First and foremost, we want your ideas. We're hoping that since those ideas are being generated by you, you'd want to be it. But you can say, now we're going to sit this one out, we'll do the next one. You could like sit it out for as long as you want, you're still part of the network. Yeah. So it's a very, very low bar to be a part of the network for a practice perspective. We're also offering incentives, CME, maintenance of certification, things like that as well.
No financial?
Financial?
Like, do you pay the practices to do any of that? Do they get reimbursement? Do they pay for MA time? And
Yeah. So it's our hope that through the ACCEL pilot project, as we help the researchers develop a budget, we'll be able to budget something for that, for sure. We'll definitely be able to offer incentives for like the practice, the practice lead person. But also, we are staunch supporters of if patients provide information, we want to reimburse them, as well as practice personnel. We do give a yearly stipend to each practice that's in the network that they can use however they want. So that is a little bit of an incentive.
Unlimited Starbucks coffee thing?
Yeah, just kind of, yeah.
So Lee, you're at 33 practices. Do you see it expanding, or is there a plan to sit tight for a while?
No, we got a message from the title. The other thing is that now that more networks are having like residency programs,
Yeah.
that need to have some sort of scholarly part of the residency program.
that's right.
They're coming to us to like be part of the network. Title is doing that, ED and Bay Health as well.
Good.
So yeah, we're expanding.
Good.
It may be too early to sort of comment on this. I'm not sure where you are in the GLP-1 proposal, but I'm sort of curious how you protocolize something across so many primary care clinics. I imagine it has to be something pretty simple that utilizes, resources already available in all of the different clinics, which are probably really variable. So I'm just curious, sort of lessons you've learned trying to protocolize this across so many settings.
The lesson we learned from the experts from other PBRNs is that you start out simple. We call it the low-hanging fruit. So as I say, we hope to eventually use EHR, but we haven't figured out how to harmonize all EHRs yet, but we are working towards that. So the first study, the kind of like the sine qua non of PBRNs is something called a card study. So it's basically you have a question. So the clinician sees a patient that has to do that question. When they come back to do their EHR, they have a 3x5 index card with a question or a check off or something like that. That's the data. Then they put it away. So our initial studies are going to be that simple, basically.
Yeah.
Because first of all, we want to get people excited about the research, and we want something that's relatively easy. It's not time consuming. As we get better at this, we'll be able to identify more complex ideas.
I think that makes total sense. Like, I don't know how you would do something more complex. So are you mostly focusing on sort of data collection right now about sort of their practice, or are you trying to implement like practice change as well?
Well, our goal is implementation science eventually. And again, because of that research practice gap, the most effective research is stuff that you could implement in your practice right away. So we're not just gathering data on like epidemiology and stuff like that. We want stuff that the practice, first of all, they'll get their own data back, and then they'll get the aggregate data back. And then that will allow them to go to their QI programs and everything else, saying this is the data locally, this is what we need to do.
Yeah.
So it's kind of like baby implementation science. Eventually we'll get up to like the real stuff.
I think you have to start there. That makes sense.
Lee, with the ACCEL CTR being Delaware oriented, this does not go beyond state lines?
Unfortunately not. Although we've expanded the lines a little bit, we have two practices that are on the border of Maryland and that are in Maryland, but on the border, and a significant percentage of their patients are Delawareans. So we've been able to utilize those two practices because the data will be Delaware data.
Good.
Now, there are things called meta PBRNs. So there are different PBRNs in different states. Eventually, we're all going to do research together.
Yeah.
Where we'll have a Delaware component, a Maryland component, a Louisiana component, things like that.
Good.
Great.
Okay,
I don't think my stuff's gonna add much to the discussion. Yeah, I'm very sure, but I almost thought about using this as a focus group. And who here is involved in a primary care practice? Okay. Oh, hi. Okay, good. So I'm sitting here because Lee and Barb and Alice have done such a good job moving this thing forward. I'm director of pharmaceutical trials at Christiana, and I am the PI for the Christiana-based ACCEL CTR group. And I was going to use this as an opportunity to introduce pharmaceutical clinical trials to this organization. Way too early for that, obviously, but Lee and Barb and Alex have moved this forward so successfully. We now have 33 practices, and essentially a practice network. And you brought up the very reason I'm here. You look at clinical trials in the real world, they're actually very important. I first got involved in research during the HIV days when they brought the NIH sponsored the community protocol base to get interventions in the HIV population into the real world people that were, they're not the ones showing up like Lee already pointed out at the ivory towers, and to broaden the population base of the study. And I've been, I wouldn't say desperate, and that's been a long time. I've been attempting to move our pharmaceutical trials from the inpatient arena to the ambulatory arena, and it's very difficult to do. I'm not sure this is the right setting to do it, but we're starting to plant the seed for that because this is year 13 of the ACCEL, and it's year 3 in this cycle. So if we're going to start to have that discussion, I was going to start it now. And the question is, what barriers exist for that? Is it really truly beneficial to the practices? I don't think we know the answer to that, but I do think that the issue of, and Lee mentioned this already, sustainability of this process. We're going to have 33 practices in a practice-based research pattern, a group that are collegial, that are bonded, that in theory will unify and be a force and can be really good for clinical-based research and for asking questions, but also they need to sustain themselves financially. And I think clinical pharmaceutical trials are a possibility to do that. Now, I was going to talk about it today in sort of a focus group manner, in the sense that, well, what do people think about that? What should we focus on? Because frequently there's the negative thing of, oh my gosh, you're sleeping with the enemy. If you're, in fact, I had a high level person here say that to me in a meeting, you're sleeping with the enemy with your work. Well, then don't support my work. But the other question is, every single medication or intervention that is currently FDA approved went through the clinical trials process. So there's benefits. Benefits are for primary care providers to be involved in new agents as they come through. And I think patients have a very positive feeling about it also, in the sense that I'm not sure they feel like the guinea pig people talk about. So I was eager to sort of pick people's mind on that topic. And we can do that in future meetings. But I do think there's a role for clinical trials. I do think that, there are 4 phases of clinical trials. The ones, right out of animals go to humans. That's phase 1. We don't do those. Phase 2 and 3 are interventional trials. Drugs that are relatively safe being tried in humans, and not just, interventions we're talking about as well. So I think we were going to use this as an opportunity to bring that up. I don't see it's going to add much to this conversation, but I think that potentially exemplifies, I wouldn't say the power, but the opportunity and potential to expand that armamentarium and add another sort of another opportunity for clinicians that want to participate in research. It can be very well received by patients and very well received by practices. And there is some potential for financial stability. I think that as funding is going various directions, there's one area where when we get funded at Christiana, we don't lose money. Maybe not as much. But in theory, we can do it, so we don't. So you need to have a base. So I'm just throwing that out for discussion. Lee, we'll probably bring it up at another meeting at some point in time. I don't think moving from you to me in this discussion would benefit anybody, because, gosh, this was You guys have done so much on this. It just, I think it's beyond where some of the ACEL leadership thought it might be at this point, and that's good. It's really good. Because we're knocking on the door, do some things like already. So, but I'm just gonna add that to the piece. That's why I'm sitting in the room. And I'm gonna stop
I
there.
had something to that because we talk about this all the time, but it just, the way you phrased it today, and I think even after the meeting today, I think one of, the opportunities here is that if we, create this environment or this network where we could potentially sustain clinical trials, it offers opportunities and practices and places that we would not see. And, typically a pharma company comes and, you go through a feasibility study to see, do you have the patient population? Do you have the people on site? Do you have all these resources? They're not interested in working in with a one-off practice, sorry to say, probably down in Seaford that does not have that infrastructure. That population, they're not in the mix for the research, right? This is what we go back to say, sorry to say to, older white men, but, a lot of our research, that's our population here. So I think that there's so many benefits. And it has to start simple. We really have to make sure the infrastructure is right. Research is important and there's a lot of regulation and we have to be very thorough that, we keep the safety of the patient,
Well, but we have those resources.
Yeah, so
Memorial has those
by building
resources.
that, right, and
We have the
expanding.
resources. The state has people that are interested, and we can provide a lot of resources that someone else doesn't have to worry about. And not in such a way that we're gonna, it's not gonna be a one-way street.
Kind of like a hub and spoke, but, really,
is,
yeah.
and those early upfront, all the reasons why you lost money in research were all that infrastructure.
Yeah.
And
that's-
all that's taken care of, and
Yeah.
all you have to do is talk to your patients who are your patients, and that's the
Yeah.
success in getting someone to feel comfortable in
The trust piece that we talked about all day, right?
The
It's like,
best of both worlds, yeah.
Well, I think having it come from the clinicians is the only way. It's that whole trust discussion today. And you've approached them in such a transparent way. I mean, I think that, in Delaware, there's that Newcastle County downstate thing. I mean, no one's gonna say that doesn't exist. There's that who's Christiana, the big bear that sleeps where they want. But I think if we can dispel that sort of mythology and be where we ought to be and help all Delawareans.
Great.
There's definitely an efficiency issue as well, because as researchers, when you figure out your sample size for power and everything, you wonder, how can I do this? But from the clinician, if we have 33 practices, it requires maybe only 10 patients per practice. That's doable.
Yeah.
So a big study can be done very, very efficiently through a network without an overbearing load on any one particular part of the network. So it's efficiency numbers. So we have a table out there with a QR code. You're welcome to do that. We'll hang around if there are any other questions, but thanks for your input and for listening to this. Hopefully every year we'll have more and more research that will report.